Good afternoon, and thank you so much for this kind introduction, Dr. Lutz, very kind. I was quite impressed listening to the fruits of your workshop, and actually I apologize that I was not able to follow at least one or the other workshop. That is because Lugano is quite far away from this place, and I have to be back because we started with our new semester, and so that's the point. So what I'm going to do in the next 30-35 minutes is I will shortly talk about literacy. And let me start with a very simple story. The story begins in 2015. In 2015, the Federal Office of Public Health in Switzerland conducted a survey, a representative survey in Switzerland, and it was supposed to measure the health literacy of people living in Switzerland. And here are the results. The results show, if you look at Switzerland here, that Switzerland is not at the top of the health literacy survey. Actually, it's better, it still performs better than Bulgaria, Spain, and Austria, but actually worse than others. In a kind of official comment to these data, the Federal Office of Public Health draw two conclusions out of that. Number one, compared to other European countries, Switzerland has major problems when it comes to understanding of information in the domain of disease prevention. Second conclusion, particularly with respect to vaccination, Swiss citizens show greater problems with understanding, 50% very difficult or difficult compared to other European countries. Here's my question for you. Do you buy this? Yeah? I don't. Good. So, because of the problem that, according to this survey, Swiss people were less literate when it comes particularly to vaccination issues, the Federal Office of Public Health decided to replicate this kind of survey in 2018. And they asked us to prepare the survey, and we did so. And we actually came up with other data. And you can say, well, that happens. Yes, it happens, indeed. But before I show you the results, let me just shortly show you how health literacy has been measured in the survey in 2015 and how we measured that. So in the survey in 2015, it has been measured. The entire survey was based on a European survey of health literacy, which has become a proper kind of well-known tool here in Europe. And among other items, they used 3 items for measuring the vaccination literacy of people. Here are the 3 items. On a scale from very easy to very difficult, how easy would you say is it to find information about vaccinations that you should have? Number 1. Number 2, on a scale from very easy to very difficult, how easy would you say is it to understand why you need vaccinations? And number 3, on a scale from very easy to very difficult, how easy would you say is it to judge which vaccination you may need? So these are the 3 items which were used, among others, in the 2015 survey to measure the literacy of Swiss people, particularly the vaccination literacy. We used them as well, and we added another scale. We also measured in our survey in 2018 the objective knowledge of people about whatever actually matters when it comes to vaccination. We used a scale that has been previously developed by colleagues at the ETH in Zurich, and it's actually a very good scale. We like that a lot. It's what we could be called the objective knowledge scale, right? So we have 2 measures. We have the subjective health literacy. I will talk about that in terms of using the term subjective health literacy. Why is that the case? Simply, if you have a look at these 3 items, it actually asks the people, how would you rate yourself, right? And then I will show you the data based on the objective knowledge, what people have, okay? Good. Look, to show you the overall picture of these data is very simple. So think about objective vaccination literacy or objective vaccination knowledge. Well, you can group people in either high or low, and you can do the same with subjective literacy. Okay, subjective vaccination literacy is the one, as I shown you before, based on the 3 items. Also, that can be people can be classified into high or low vaccination literacy. Good, let's have a picture. That means we have actually 4 cells. We have those who think they don't know a lot about vaccination and who effectively don't know a lot. And there are those who think they don't know a lot, but they actually, as a matter of fact, know quite a bit. And then you have others, those who actually think they know a lot and effectively not so much. And of course, then you have the ideal scenario. These are the people who know a lot and who are self-confident. They know that they know. Okay, that's the picture. Let's look at the data. So to start with a group of low, I call them, they are clueless and insecure, right? So 13% of our representative sample were actually clueless and insecure. They didn't know anything, but they admit they didn't know. Good. Now, what about those who actually said they don't know, but as a matter of fact, they knew quite a bit? This is in the group of high. The one call them informed but insecure. Well, this is it's a small group, 6%, but they are there. Now let's have a look on the more interesting part, okay? Here are those who actually say they don't know, who don't know anything or very little, but who are convinced that they know a lot, okay? This is 32% of the population, okay? And then you have the last group. Again, that's the idle group. The group of people who actually say, well, I know that I know, and indeed, as a matter of fact, they know quite a bit. So that's about almost 50%. That's an interesting picture, because now that perhaps helps us also to explain what happened in the survey in 2015. People were measured on their subjective literacy, and they thought, oh, I know a lot, but as a matter of fact, they didn't know. And interesting enough, I think that's actually a real problem in Switzerland. People rather tend to say, well, perhaps I don't know enough, but they know even more than they think they know. That might explain the problem here. Good. So now this leads me to another point. Well, okay, nice distinction between high and low and high subjective and objective knowledge, but is there any effect of these 4 groups? And as a matter of fact, yes, there is an interesting effect. Look actually at this point, I just show you the number of the existing vaccination according to these 4 groups. Right? Here, those who were clueless and insecure has the lowest number of vaccination. Those who actually were clueless, you remember, low objective knowledge, but very self-confident, they had the second lowest number of vaccination. The third group was the one that was informed but insecure, and the biggest group was actually the one that was informed and self-insured. They had the highest number of vaccination. Well, that's an interesting picture. So it's not just an academic distinction. It actually has some serious consequences also. Okay? So if you want to make sure, if you want to change anything, well, it's good actually to change something on the level of the objective knowledge, not so much on what people think they know. That's the story here. Good. So let me give you the bigger picture of the story I just told you. The bigger picture is we talk in the literature about a bias, perception bias, and that actually is called the unknown unknowns. So, with other words, you may have heard about the Socratic Paradox. long time ago. That was Plato, when he came out and said, look, I know that I don't know anything. That was exactly Socrates, right? And that's exactly something like that we have going on here. The bigger picture tells you it's interesting to see that people sometimes overestimate their literacy and sometimes they underestimate that. What we are interested in is exactly to understand what's going on in the right group. Good. Now, let me open another chapter. If you think about the problem of the subjective health literacy, I would call that, and I hence will call that, that's the problem of a sort of empowerment. Why is that the case? Well, because people, as you know, when we talk about empowerment, we talk sometimes or often about self-efficacy of people. And that's exactly the kind of the way how people look at themselves. How am I actually? How am I good? And actually what I would suggest is the best way is to disentangle or separate literacy from empowerment. Not to say to separate them completely, but first to disentangle them, and then we can bring them both together as two different or distinct dimensions of the way how people actually think about their own health. Let me actually suggest the following picture. If you think about empowerment, that's as being one of the dimensions of the way how people look at themselves, and the health literacy. Now this time, when I talk about health literacy, I don't talk so much about the subjective way or subjective perception of their own literacy. I talk about subjective or health literacy in the terms of something that is objectively existing. Now, have a look at this 2x2 design. What we can say, that's my conclusion, is if you have people who are, objectively speaking, very low in their literacy, and in the same time, they also think they can't change anything in their life. These are people who are high in need. Our ideal group of patients, or health consumers call them, would be what I call the effective self-manager. These are people who, number one, show a high level of self-efficacy or empowerment. They feel empowered, and the same way, their being empowered is covered by a certain literacy as well. But then now let's come to the more dangerous, or the two other cells. The other cell is you have the group of those who actually, objectively speaking, are high literate. But they would not consider themselves as being high literate. What happens to these people? Well, they constantly run back to the doctor or to other health professionals and just want to be affirmed one again and again and again and again. These are therefore needless dependent. They could be much more autonomous, but as a matter of fact, they are not. And then let's come to the most critical cell. That is the group of people who actually think themselves as being very literate, but as a matter of fact, or highly empowered, that's the same as that. But as a matter of fact, actually, all their kind of high level of empowerment is not covered, is not backed up by any kind of objectively literacy, which I think is the a crucial challenge for our times. Why? Because this is exactly the group of people who, for example, look at the internet for health information, find some information, right? And then get back and say, well, I can fix this problem by my own. I don't need any kind of doctor here. I am actually highly empowered. Whether they are really literate or not, that's actually a different and good question also. So this, I think, would be the kind of great challenge we have to face. Good. By the way, when I talk about empowerment, what do I mean with that? That's a very big story, and I mean, you yourself have thought a long time about that. I've seen some of you in the presentation before. So there's one way to think or conceptualize empowerment, which I like very much, and we applied that in the health communication literature. It goes back to a study that originally has been done in a complete different area of research, actually in management studies. And they came up with a distinction which I think is very helpful. When we speak about empowerment, we actually have 4 different aspects of empowerment in mind. And I'm speaking now about patient empowerment. Number 1, call somebody empowered to the extent that the person actually sees some meaningfulness in what he or she is doing. Second, the aspect of she or he feels competent in doing something. Third, she or he actually sees also a sense of autonomy to manage their own disease. And last, it actually also sees that she has an impact in what she's doing in this kind. A person who is empowered in the health domain, I would say, shows to some extent actually these 4 aspects of being literacy. Now here is again the picture, health literacy and empowerment. These 2 components together, according to what we think is the kind, would explain health behavior in the positive or constructive way as well as in a destructive way. So better to disentangle health literacy from empowerment. Both together then lead to what you may call actually healthy or health behavior in a constructive way. After all, what follows is that the main challenge is to move people from this cell or this cell to this cell. Help them to become effective self-manager. And not just by making them feel great, but also helping them becoming more literate in what they're doing. So both are important. You cannot be really constructive unless you show both dimensions, so effective as well as also literate. Now you can say, nice idea, typically an academic who's talking here, so what's the point, right? What's the consequence? Well, we started doing a couple of studies. I just want to show you one consequence. We did a study in Hungary, and it was quite interesting. We used as a kind of performance-based measure of health literacy, we used the news title sign and a short Toffler. In a minute, I will tell a little bit more about the measures of health literacy. And actually, we used also our health empowerment scale, which we found. And it was quite interesting. Indeed, as a matter of fact, those who showed high level of empowerment and high level of performance-based literacy were the one who actually showed also the best health outcomes or best status, health status in the fact. Those actually, in the opposite, who were low on both dimensions, literacy as well as empowerment, were those who performed very poorly. Good. Now, let me say something about measures of health literacy. Things go together. One is the conceptual way. What do we mean when we talk about literacy, health literacy, or empowerment? That's number 1. And the question, or this conceptual question, goes along with the other question. How do we measure health literacy? And look, this is a long story, and I'm sure that also my colleague will say something later on that. But let me actually give you a very short update on that. As we have seen before, there are different ways of measuring health literacy. And we saw already one measure, which I personally, it's just my personal take on that, would say it has some kind of downsides. This is when you ask people, how would you estimate yourself in your terms of literacy? So think about literacy measures that might fall in 2 different categories. One type of category of literacy measure is kind of based on your own impression. How would you think yourself? Are you good? Have you any difficulties or not? And that sometimes leads actually to the problems which I've shown before. And then there are other types of health literacy measures which call them performance-based, such as people actually have to show that they really know something and it's not just their own rating. It's called performance-based, and we have a couple of measures who indeed do not get into the self-rating but actually try to measure the performance of people. 2 of them are the Toffler or short Toffler and the news vital sign. These are probably the most widely used measures in that. Short-Töffler is actually a pretty long measure, and it has some other problems. It has the problem that it's actually only a measure of functional literacy. It doesn't measure anything else. News Vital Sign is a measure which I like, but it also has some limits. It is good in the sense that it actually really measures performance of people. It has the downside that it's pretty much on numerical things and tasks than anything else. But then we have a lot of self-report measurements. If you look at the health literacy literature, I would guess that about 85% of all studies that have been conducted on health literacy in the United States and abroad, so beyond the United States, use the Short-Töffler measure. Only few then use the brief health literacy screen, and now more and more people use the European health literacy survey, which, as I've shown before, is a sort of self-report measurement, so self-rating. How would you think yourself is doing? So this is just about some problems. The brief health literacy questionnaire is also this kind of subjective rating, and it was introduced in the United States, and we replicated that in about 12 different countries with different cultures, and the overall result was very simple. It does not really hold the promise. It doesn't work at all. I'm sorry to tell my colleagues in America, but it doesn't work at all. So it got also published. So there's no point. It does not reflect any kind of performance-based literacy. This is the Short-Töffler. So if you are really curious now, you can run through that and check how literate you are, right? But you don't have to do that. It works like that. It's a kind of gap that you have to choose the right option out of 4 possible options. If you get the right one, then you get 1 point, otherwise 0 point. And then there are 36 items in this Short-Töffler, and if you get all, then it's fine. If you get more than 20 correct, then you're still considered to be literate. If you get less than 80 correct, then you're marginal or even inadequate literate. Okay. So, next. Why does health literacy measure? Well, to make a long story very short, here you have a list, which, by the way, is not a complete list, of outcomes that have been measured with health literacy. Very simple. People actually collected data. In most of the cases, as I said, 85% used the Short-Töffler measure, so collected actually data on the people, on the patient, consumers, and so on. What about their health literacy? And then they looked on some clinical data or other data. And these are almost all correlational data. So it's all about high literacy means high health status. Low literacy means, for example, people are not capable to control their asthma or whatever, right? That's the kind of equation that people show us all the time. Good. Now let's have a close actually look at this correlation, at this path, at this kind of very simple path that health literacy actually leads to health outcomes. And I just want to give you one example, what we know about that. Is that true? Is it always true? Well, as we have seen, one thing that actually makes a difference is how do you measure health literacy? Is it a performance-based measure, or is it actually a perceived-based measure? To call these 2 types in a different way. And then, of course, what kind of health outcomes? There are some very classical topics in the health literacy literature. One is asthma, the other one is diabetes, diabetes type 2. The question is, if you have a closer look on most of the studies that have been conducted, you actually will find that in most of the studies, you have an R-squared which is smaller than 0.3, which means it just explains, technically speaking, 9 or 10% of variance. That's all. So you have 90% of variance, which is unexplained in that. It's not very impressive to be true. right? So a lot of research still needs to be done to show what's going on here. If you show only that health literacy matters so little with respect to the health outcomes, so why don't we make such a big story out of health literacy? I think we should keep that in mind. And the field, to be frank, as far as I would say, is still at the very beginning. It's still a long way we have to go and understand better what is going on here. I will now shortly walk you through a couple of slides, and I just will concentrate on health literacy on one side and diabetes management on the other side. Okay? How much time do I have still? 5 minutes. Oh, I can do that very shortly. Good. Very shortly. That's it. Good. So, to summarize the story, we did a meta-analysis of all studies because diabetes, as I said, is actually the biggest field here. And to summarize the story, it's very simple. Actually, as a matter of fact, as you will see here, there are only, some studies actually have shown that there is something going on, but as a matter of fact, it depends very much on which measure has been used. Glycemic control is a kind of hard outcome measure. The only health literacy measure that really works here are the performance-based. If you use the self-perceived rated measures, nothing is going on here, okay? Now, the health literacy measure, how does it lead then to diabetes management? Here's the story. It probably leads in the following way to an increased diabetes management. Higher the literacy level means that you actually eventually learn more about diabetes. And the more you learn about diabetes, the more it is likely that you're also capable to manage your own disease. That's the story. So what we need to do is just a more technical thing. We need to include other variables that would actually help us to see the entire picture. Just to talk about health literacy it's only the beginning of a long story. As a matter of fact, what is interesting that this got just published is these self-perceived rated or self-perceived measures of literacy, health literacy, are pretty weak, I have to say. Good. That was one of the minute, right? I have 3 minutes left. Is that correct? Okay, Andreas. So here's the story. I heard that this was also of concern for you, so let me summarize the next story, actually, which is taught on the next slide. So I was involved in a study, in a very nice study, which we conducted in Sweden, in this area. It's the northern part of Sweden, and it's an exciting population-based prospective cohort study on CVD prevention. And we built in this study, actually, literacy measures. Okay? The question is, number one, does literacy matter at all? To anticipate, yes, it does. But the much more interesting finding is another one, and that might be of interest for you. What we did is, it was a kind of randomized controlled trial. So one group, as you can see, that's a big group of almost 3,500 participants. One group, the treatment group, got a visual presentation of their own risk. The risk was estimated based on clinical scores, such as Framingham risk scores and a couple of others, thickness of coronary arteries and so on and so forth. Just a couple of these clinical issues. The other group, the control group, didn't get anything except that what everybody actually gets, just a warning of the matter. And the question is very simple. Is there any difference if you inform people by using this visual material? I show you something like that here. That was actually, I apologize, that's Swedish, I don't understand that, but I believe my colleagues, right? So it says, look, this is a high risk, you're in the high risk group. Just red. And green, of course, means you are really good, so move on, okay? So the question then is, does that matter at all? If you show patients, if you visualize their risk, does it help? Does it matter? Okay, let's have a look at those who are showing high health literacy levels. This is this is the overall effect of our intervention on the Framingham risk score. As you can see, there was a huge difference. those who actually got the intervention really decreased significantly. Here are the data. You see, typically the risk increases from wave to wave we measured. Now, in the group that actually was for the participants who were in the treatment group, it decreased quite significantly, and it's a strong effect. Okay, good. So far, so good. Now, let's look at those who are in the high literacy group. For those, again, I owe you 1 minute of my talk. So, for those who are high literate, this intervention had a huge effect. But for those who were in the low literacy group, there was no effect at all. Independent from whether the participants were in the treatment group and got this visualized presentation of the risk or not. With other words, and that's actually a kind of surprising finding, because that is, as you would have expected, that presenting in a visual form the risk to low literate people would make a difference, and it did not. So we are right now in the next wave of collecting data. We'll see what's going on. But there is, of course, one possible explanation, which brings me back to health literacy and empowerment. Here's the possible explanation. We still need to work on that. If you have people who are low literate, these people perhaps don't believe that they can do anything, which actually is a question of the empowerment, of the low empowerment things. So we'll still have to look at these data, and we can actually show that because we have measures for the empowerment literacy, for the empowerment as well in this study. That might be one possible explanation of this surprising finding. With other words, there must be something else going on. So solving the literacy problem by using visual pictures is not the entire story. It might lead to such a kind of finding that you won't find any kind of difference. Let me actually conclude with that, and thanks for your patience.
Thank you.